So today we're going to talk about chest trauma. This is something that we borrowed from a Dr. Saeed Mostafa. He is a professor of, I believe, thoracic surgery in that university in Yazd, Iran. And what we're going to talk about is how to assess, how to figure out, and really what presents us with a dangerous chest. Not going to be dangerous to us, but it is going to be dangerous to our patient because we've sort of talked ad nauseum at this point about all the important structures that live in the chest. Not to mention the fact that yesterday we talked spinal. Well, we talked pretty lengthily about how those 12 thoracic vertebrae housing the spinal cord that goes right through that spinal column, that little hole in the middle of all of those vertebrae where the spinal cord passes through, is just the back of the chest. It is the posterior portion of our patient's thoracic cavity, and anything and everything that can injure the chest can also injure the spinal cord, the spinal column, any of the vertebrae, and cause some pretty serious neurologic deficit. That being evidenced right here. Clearly somebody was upset with this individual, and if you look at the amount of stab wounds and the amount of holes that are punched into this person's chest, it is the posterior part of the chest, but it's still going into the same cavity. It still has every ability to puncture those pleural linings and start developing a tension pneumothorax or just a regular pneumothorax, or with all that bleeding, a hemothorax, and cause some problems with our patient being able to expand and contract their chest. So it'll cause some problems with our patient being able to ventilate appropriately. It'll eventually cause gas exchange issues. It will cause pressure issues inside the chest. Start thinking tension pneumothorax and obstructive shock. And we'll start to see some pretty significant signs and symptoms and some pretty real for life sick patients with some pretty rapidly developing problems. We'll go through some anatomy and physiology here of the thorax. We're going to talk some main causes of chest injuries. We're going to talk signs and symptoms of our chest injuries. Then we will get into the nuts and bolts a little bit and talk our different type of chest injuries. And last but not least, we will get into the treatment of those injuries. There are two specific ones that we are going to be looking for all the time during B of our primary assessment. That's why I'm begging you, when you are doing your primary assessment of a trauma patient, get in the habit of exposing that patient's chest so you can see it. Get in the habit of listening to your lung sounds. We're going to inspect, palpate, and auscultate, albeit quickly during the primary assessment, our patient's thoracic wall, looking for a sucking chest wound. So frothy, bubbly blood coming from a hole in the anterior portion of my patient's chest, or even the posterior portion of my patient's chest when I get a look at it. That is going to be a sign of a pneumothorax. That pneumothorax needs to be appropriately managed so that it doesn't continue to develop and doesn't turn into that tension pneumo and doesn't really start to have some more negative effects of my obstructive shock. The other injury we're going to be on the lookout for is going to be a flail segment of chest. That flail segment, if you guys saw it in the book, it's 2 or more ribs broken in 2 or more places. That's going to be our book definition. You're going to see it as some instability. The real trigger word that we're looking for, especially for exam purposes, is going to be paradoxical motion. Part of that rib cage is moving independently of itself, and it looks almost like a seesaw. When my patient expands their chest, that flail segment is going to suck in. So we're going to see a divot. When my patient contracts their chest to exhale, we're going to see that flail segment poke out of my patient's chest. There's some great videos of it, and we'll see that in just a little bit. But that's something else that we're going to really be on the hunt to fix. That's why making sure we do a real solid assessment of breathing during our primary assessment is going to help us figure out what is this injury, where is this injury, and how negative of an effect is it having on my patient's ability to move gas from the outside to the inside. Because initially, neither one of those things is really going to have a huge effect on gas exchange. If there's gas there, it'll exchange. It's going to happen. What these two injuries really do have that is limiting to my patient's ability to respirate and ventilate is the ability of the lungs to expand and contract appropriately so that there's enough gas down there. So ventilation becomes an issue. Here's our anatomy. Told you it would be a brief overview. We have the right and left lung, we have the heart, we have the diaphragm. These are really the structures of importance inside our patient's thoracic cavity. We'll talk a little bit, probably not a whole ton today, about the actual vasculature, because we know the aorta and the superior and inferior vena cava run right through the middle of the thoracic cavity as well. So for argument's sake, I think we can say if either one of those gets punctured by something or has an issue from, say, obstructive shock, our patient's going to have some negative results. Let's just call it what it is. It's hemorrhage. In the middle there, we have the trachea, so the lower portions of the airway. We start branching off into the left and right main stem bronchus. Those bronchus eventually branch out into bronchioles, and then we get down to those alveolar ducts, and we get to the spot where this external respiration actually takes place. That oxygen moves out of the alveoli into the deoxyhemoglobin blood. The hemoglobin picks up that oxygen. In return, it drops off its carbon dioxide. The carbon dioxide goes into the alveoli. The blood goes back to the heart. The heart pumps that blood around. We exhale the carbon dioxide, and life goes on swimmingly. The mechanical pieces that make all this happen, we're going to talk here about pleural space, intercostal muscles, and the diaphragm. What's that pleural space's function? What's it for? We have the parietal pleura that lines the inside of the rib cage. We have the visceral pleura that lines the outside of the lungs. And there's some really important structure and function going on there.
It keeps the ribs from rubbing against the lungs and vice versa.
Yeah, so everything just kind of moves smoothly because there is a lot of movement with every single breath that we take. The diaphragm, when we take a breath in, it is going to contract and pull downward and anteriorly. Our intercostal muscles are also going to contract and pull our chest wall out and away from our body, in turn making that space bigger. And when we make that space bigger, we make the pressure inside of it smaller, because this is supposed to be a closed system, supposed to be airtight. And by doing that, we create that larger space and that smaller pressure. Gas rushes in, fills up our lungs, gas exchange takes place, and we just keep going. Out with the bad air, in with the good. We exhale that carbon dioxide. All those structures that expanded now just contract and go back to rest. They get smaller and create now a higher pressure inside of our chest. That higher pressure forces all that bad gas out, so the CO2 gets sent on its merry way, and our respiratory cycle is triggered by hypercarbic drive. So that increase in CO2 triggers us to exhale, which is truthfully the beginning of a healthy person's respiratory cycle. Out with the bad air, in with the good. We would be remiss if we didn't mention some of the vasculature here in at least a little bit. Inside our thoracic cavity, inside our anatomy, we have the ascending and descending aorta. We have the aortic arch. We have the aorta passing right through the middle. The aorta's job, what is it?
To pump blood out to the body.
Yeah, it is transporting blood out to the everywhere. The aorta sends blood oxygenated by the lungs and sent out by the left ventricle to every single spot in your person. So clearly, any type of leaking from the aorta is, the recipe for a terrible, horrible, no good, very bad day. Arguably equally important structures, we have the superior and inferior vena cava. Superior meaning it returns blood from the structures higher up in the body than the heart. Then we have the inferior vena cava running through this same neighborhood, returning blood from the inferior or lower portions of the body to the right atria. That right atria stores that blood for a half a beat, and when the valves open back up for the ventricles to fill, blood goes from the atria down into that right ventricle. The right ventricle pumps it out to the lungs in order for it to drop off carbon dioxide and be oxygenated. So any problems with our vena cava is also going to be a recipe for a pretty negative day. The venous side of our vascular system is not under pressure. So we will see if we have obstructive problems in the thoracic cavity, say things like a tension pneumothorax or a pericardial tamponade, causing those signs and symptoms of obstructive shock. We'll start to see some jugular venous distension because that obstruction is limiting blood's ability to get back to the right side. So it's taking preload out, which means the venous side of our system is going to back up, and we will start to see some distension in those jugular veins. There'll be those big honking, like bulged out jugular veins we see off the side of our patient's neck. So what do you think some of the main causes of trauma to the chest might be?
Blunt force.
Blunt force for sure. So a wide / heavy object is introduced into the chest either by compression, so something is just squeezing the chest, or at a high rate of speed causing internal and structural damage. You got it. What else?
Penetrating. Knives, bullets.
Who's next on the list? You got it. Some form of projectile enters the chest and thoracic cavity, causing either a small hole or a very large hole, depending on what the penetrating object was. Both of these can have equal amount of problem. It doesn't have to be this great big wide gaping hole, blowing pieces of our patient's chest apart. Even small holes can really cause a bit of an issue for our patient, and we need to know that we need to fix that. And then compression, I sort of lumped that in with our blunt force trauma, but the chest is stuck between a rock and a hard place. And that chest being stuck between a rock and a hard place is causing some compression. I think we saw a question like this on that group testing, EMS testing thing we were doing here in class the other day, where it was talking about a patient who was pinned and unable to expand his chest wall. Well, if my patient can't expand that chest wall and create those pressure differences we're looking for and the ability to ventilate, we're going to go ahead and ventilate for them. Our penetrating trauma, that's where we're going to be sealing our patient's chest with things like occlusive dressings. Blunt trauma is generally what we talk about when we think of things like that flail segment. Think of it, if you have 2 or more ribs broken in 2 or more places, it would be sort of like if somebody used a Coke can, tall wise, to punch a hole in your rib cage. So we'd have ribs broken on either side of that can, and it would be just kind of a wonky bit of chest wall that really doesn't look anatomical and doesn't look really great. One of the problems with that flail chest that we we'll talk about is sometimes our patients still have the ability to expand their chest wall and get good, airflow and create those pressure differences we're looking for. But what do you think we can say pretty straight away here about that many ribs broken in that many spots?
Well, it's definitely going to impair the lungs.
On top of impairment, it's gonna hurt. So we'll see patients who are consciously forcing themselves to breathe inadequately just based on the amount of pain it causes them to take a breath and expand their chest. So that's something that we need to be on the lookout for as well. When we do that rate, rhythm, and quality, well, my quality assessment of my patient's breathing is, are they expanding their chest wall big and wide enough to get enough gas flow to get it down to the alveoli where that gas exchange can take place? Or are they, since it hurts so damn much, are they taking these teeny tiny itty bitty little breaths that's keeping all that gas in that 150 milliliters of dead space because it is just too painful for them to breathe? So look, listen, and feel, IPA, is really kind of important when we're looking at a chest trauma. That is one of those things that we can't just kind of brush by, because it may cause us to either miss or not pay enough mind to something that really can be a deadly situation.
Well, that, not to mention how much damage the busted ribs are doing to everything on the inside.
Oh yeah, because when they move, they're just going to poke holes and grind things up and just grate like nobody's business. So the problems just continue to potentiate and stack up on one another, and before you know it, it's difficult to manage at best. So the injuries we're going to talk about here are a simple or closed pneumothorax. I know we've seen questions about a spontaneous pneumo, and we'll talk about some of the goings on with that. We'll also talk about an open pneumothorax. That open pneumothorax is going to most likely produce the signs and symptoms that we're looking for when we talk about a sucking chest wound. The trigger word for that, if you're thinking about it, is going to be frothy, bubbly blood coming from the patient's chest. Well, what do you think is causing all that frothing and all that bubbling? The hole is causing the bleeding, but why doesn't it just look like normal bleeding?
Because the air coming out of the lungs is just basically bubbling it up like if you blew into a straw into a milkshake.
You got it. That frothing and that bubbling is pointing me right towards the idea that there is underlying damage to that lung tissue. And that damage is causing air to leak into that chest. And left untreated, that air leaking into that chest will go from a simple or an open pneumo to this killer right here. Now, one of the things we've told you guys to check for is jugular vein distension and tension pneumothorax. And also tracheal deviation with a tension pneumothorax. And I gave you guys a brief insight into who generally finds that tracheal deviation that we're looking for so doggedly. Who do you think sees that first? I'll give you a hint. It's a ride that nobody wants to take any day real soon.
Medical examiner?
Yep. He's the guy that finds tracheal deviation. And the medical examiner finds tracheal deviation because some of them, either the tension pneumo just developed ridiculously fast and there was nothing anyone could do about it, or some of the more subtle signs and symptoms of shock were overlooked, and that tension pneumothorax just grew and grew and grew and grew and grew. So really, for our tension pneumothorax, we're going to be looking for signs and symptoms of a pneumo, injury consistent that would cause a pneumo, Maybe we see that frothy, bubbly blood. Maybe the patient just has a hole poked in their chest and we don't. Or signs and symptoms of shock. Pair your injury. So, was this injury likely to have caused some form of pneumothorax? So start thinking about that. Is it probable? Is it likely? And if the answer to that question is yes, we don't have to wait for obstructive shock and dead patient to hit us in the face with their jugular veins and tracheal deviation. We can start preparing for that tension pneumothorax well ahead of time. And you've heard me say this before, get out in front of it. You know, be on the good side when this stuff starts to present itself. Now, if we have an injury to the chest that we think is significant enough that we could be on the heels of a developing tension pneumothorax, this would be one of the patients where we would want an ALS provider on their way to meet up with us, because they can actually take and put a needle inside this patient's chest to release all of that pressure and make them start breathing better. Its technical term is needle chest decompression. Everybody calls it darting. You dart the chest. You take that needle, you put it in between the intercostal spaces, and that air and that built up pressure comes out. And then what we'll find is the lung sound on that affected side that was trash before will actually begin to improve, because there's no more tension, there's no more pressure being built up, and that patient's lung is now able to expand and fill up some of those alveoli. And we'll listen to the chest and compare each side, and we'll see that the affected side is actually getting better. Next, we have our flail segment. We've gone over that pretty good so far. We will talk more about it, and I'll show you some stuff that actually gives you a pretty good idea of what it looks like. We will get into cardiac tamponade. Cardiac tamponade, remember, the heart is inside a sac. The heart sort of comes in its own lunch bag, and that sac is fibrous and not good at stretching. So with a cardiac tamponade, we have blood actually leaking into that pericardium. And every single time the heart beats, it gets a little smaller. So when it beats, it ejects blood out. But when the heart actually physically gets smaller from constriction inside that pericardium, more blood fills the pericardium. And then when it goes to relax during diastole and refill, it never gets back to its original size. And then the next time it squeezes, it gets a little smaller, more blood fills that space. During diastole, it tries to get back to as big as it wants to be, and it can't. It's still even just that much a little smaller. And every single time the heart beats, that pericardium fills up a little bit more, and the heart has a bigger problem trying to expand. So it physically gets compressed and gets a little bit smaller and gets a little bit smaller, causing another sign of obstructive shock. Those jugular veins are not under pressure. Remember, the venous side does not have the same pressure as the arterial side does. So they aren't going to be able to fight through that pressure to get preload and get blood back to the heart. So those jugular veins will start beginning to bulge out a little bit from that cardiac tamponade. Traumatic aortic rupture, well, that is recipe for a bad day. Trauma can cause the aorta to just sort of disintegrate. Depending on what the traumatic cause was, will tell us just how much of a likelihood there is here. But this is something we will see very, very flat jugular veins, because our traumatic aortic rupture, blood's just leaking. We are not getting blood circulated at all. And if blood's not circulating at all, blood's not going back to the heart. And there's no backup. There is just wholesale leak going on inside the chest. This is somebody who is either internally or externally, if there's an opening to the outside, pretty much bleeding to death right there in front of you, and it's going to happen fast. Traumatic asphyxia, that is that compression we talked about with the chest actually getting squeezed between a rock and a hard place. The patient, if they could free themselves, would be able to expand their chest. There's not really huge wholesale injury to the patient's ability to expand and constrict their chest. It is the fact that whatever is applying that compression, whether, you know, they were underneath their car and the jack fell and now the tire is squeezing their chest against the ground, or, you know, a building collapse and rubble is preventing our patient from being able to do it. It is some external force is causing that patient to not be able to breathe. And then we have actual diaphragmatic rupture. The diaphragm is the dividing line between the thoracic cavity and the abdominal cavity. And when the diaphragm ruptures, we wind up actually having abdominal contents. So think the GI tract, parts of, possibly depending where the rupture is, could be loops of intestine and bowel. It could be all the abdominal organs sort of winding up in the chest cavity because there's nothing keeping them separate anymore. That diaphragm, on top of being responsible for expansion of the chest wall and contraction of the chest wall, is pretty much the floor of the thoracic cavity and the more inferior piece of the abdominal cavity. So here we go, simple or closed pneumo. We have an opening in the lung tissue and air leaks into the chest cavity. Since we know that it is a closed system, that air leaks into the chest cavity with no actual ability to get out. It will continue to leak. It will continue to leak and pressure will continue to build. A lot of times we are thinking blunt force trauma with our simple or closed pneumo. Blunt trauma is much less likely to make this an open pneumo. Blunt trauma is a big object striking the chest. That's why it's called blunt. It's spread out and diffuse. So it'll cause a lot of damage, but it doesn't really have the penetrating ability of things like knives and things that people can fall on, like pipes and fences and things of that nature, that will actually poke right through. Could be something completely spontaneous too. Spontaneous pneumothorax has a very specific patient ideology. Generally, your spontaneous pneumothorax is a tall, thin white male who smokes. Why it is that, like, almost textbook, I have no idea. But your spontaneous pneumothorax is characterized by sudden onset difficulty breathing, a patient who maybe felt some sort of pop, and it is someone who generally had a very, very fitful cough for a brief period in time. It is caused by the buildup of pressure of coughing against a closed glottic opening. So when that epiglottis closes, it is rock solid airtight. And a cough being forced against that glottic opening can actually cause a spontaneous pneumo and rupture some of that lung tissue. Thankfully, these are generally self-correcting. A lot of the times you will go to the emergency room with a simple or closed pneumo, and they don't really require much in the way of treatment. They require an awful lot in the area of being watched and being assessed and reassessed. They wait until there is significant and progressive sort of lung involvement before they actually start thinking of things like chest tubes and other steps to reinflate these lungs. So the generally self-correcting nature of them is actually pretty good, because the lung tissue will eventually heal itself up. Here we have a pretty good picture of the goings on. So there is no actual hole in this chest. Some big, large, heavy object, hammer, rock, car accident, whatever, caused one of those ribs to break and puncture the lung. The puncturing of that lung caused the leaking of that lung, and the leaking of that lung has started to cause some of our signs and symptoms. So we have chest pain, difficulty breathing. Somebody tell me what tachypnea is.
Rapid breathing.
Rapid breathing. So we have a fast respiratory rate. That patient's breathing faster because now we have almost one whole half of our lung tissue not available to be used to oxygenate blood. So they feel like they can't get enough breath. So they're going to breathe a bit faster in order to try and make that happen. We're going to have some decreased breath sounds on the affected side. So when we're listening to our lung sounds near the site of the injury, our patient's lung is going down. If that lung tissue is collapsing and is not able to expand the way that it needs to and fill up the way that it needs to, we're not going to hear that whoosh like we do with normal breathing and normal breath sounds. We're going to hear very, very distant sounding or very quiet sounding breath sounds on that affected side, and that'll start pointing us towards a possible sign of a simple pneumo. Couple it together with what you see in front of you, what's being told to you. You know, this simple or spontaneous pneumo, we'll say spontaneous first, generally doesn't come with this big sort of, oh my God type injury moment. Simple closed with an injury, we're going to start coupling all these signs and symptoms together. All right, sudden onset right after of chest pain. Patients complaining of some difficulty breathing. They have an increased respiratory rate. And then I take my stethoscope and put it to their chest, and one lung sounds very much far away and very, very quiet. If it looks like a duck and it quacks like a duck, guess what? Quack, quack, it's a duck. So why don't you guys tell me what some signs and symptoms and treatments might be? So we've gone through the signs and symptoms. What are we going to do when we see those signs and symptoms?
Assist ventilations with a BVM.
So we could, but think of the nature of the way that BVM provides ventilation. We breathe and get gas in based on negative pressure. BVM is positive pressure ventilations. So we're actually now forcing more gas through that leaky lung tissue. So it's actually way less invasive than you really think that it would be. We're going to concentrate on our ABCs. We're going to concentrate on helping our patient maintain a mental status. We are going to oxygenate. We want to give this patient oxygen based on his complaint. Complaint being tachypnea, dyspnea, some chest pain after the injury. So make sure we maintain a clear, open, and secure airway. Make sure that we oxygenate this patient as long as their respiratory rate, rhythm, and quality are good enough. If you need to ventilate them, go ahead and ventilate them. If a patient has sustained an injury significant enough to cause all this type of damage to the anterior portion of the chest and the tissues inside our thoracic cavity, we have to start thinking about some C-spine control as well, and spinal immobilization and those kinds of things. We assist them with their airway as needed. If we can sort of stay within our protocol and let them sit in a position that is comfortable for them, we'll do that. We're going to provide supportive care to the best of our ability. And we're going to contact the hospital and let them know what we're coming in with, because at this stage in the game, when we're transporting, we have already requested our ALS intercept long ago.
Tommy,
Yes.
how could we, how, I don't know if you already said it or not, but, how you place the patient, like how you found them or whatever is most comfortable to them, or is it best to like keep them supine or?
So for our intents and purposes here in class, we're still operating under the premise that everybody goes on a backboard.
Yep.
So we would backboard this patient. They'd wind up in a C-collar and on a board.
Hmm.
In the field, we have a bit more wiggle room with how we're going to transport this patient. So it would probably be in a position of comfort for them, sort of half sitting at like a 45-degree angle with a collar on and still attached to the stretcher so that they couldn't move their head, but not backboarded like what we went over yesterday. Not that kind
Yeah.
of, not that kind of thing. The best thing you can do for this patient is monitor for the development of a tension pneumothorax and be ready to respond appropriately. If a closed pneumo starts developing into a tension pneumothorax, there's not a whole heck of a lot at the BLS level we're going to be able to do to correct that. But knowing that it's happening and advising the hospital more and advising dispatch that we could really use that paramedic for chest decompression is going to be sort of the forefront of every time you think pneumo, you should think, what can I do in the event that this turns into a tension pneumo? Open pneumothorax is a bit easier of a thing for us to sort of help correct that problem. And you'll see why here in just a moment. I actually have to put you guys on pause for just a second because I'm the only person in the office this morning and there's somebody outside waiting to get in. Okay, never a dull moment. We are back. Now we're going to talk open pneumothorax. Open pneumothorax, an opening in the chest cavity is allowing air to be pulled into that pleural cavity. So remember that visceral and parietal pleura, really close together, don't actually touch, but there is potential space in there. So we have an opening in the chest wall. When my patient goes to create that pressure difference, they no longer have a closed system anymore. And that gas is going to take the path of least resistance to try and equalize off that pressure with the atmosphere. And the path of least resistance is leaking in through the hole that is in their chest. So air from the outside that doesn't pass through our normal respiratory tract and doesn't get down to those alveoli comes in through that hole in the chest wall and enters into that pleural cavity. That pleural cavity begins to fill up and increase in pressure and eventually will put down the lung on the affected side. That lung will start to deflate and shrivel up and no longer be available for oxygenation. This can absolutely be life-threatening and can deteriorate quickly right in front of our eyes. Our treatment for this, we'll get to that in just a moment. But here we have open pneumo right here. You see the axillary region of that patient's chest wall is hugely opened. I mean, that doctor or whoever that is has their entire hand inside that patient's chest, and there's probably room for one or two more. There's evidence of a big one. Here's evidence of a much smaller one. That is the entrance wound of a bullet. It is still caused an opening into the patient's chest cavity. This next picture is super unpleasant, so this will also give us a pretty good look at entrance versus exit wounds, because there's the exit wound and all the tissue damage that it has caused, and it is caused probably right around the level of the diaphragm anyhow. So we can see all sorts of maybe diaphragmatic rupture, maybe traumatic aortic rupture. We might see open pneumo beginning to develop. But here's the bits and pieces. So our friend here with the gun has shot this cartoon in the chest, and we have an open pneumo. Every time that patient inhales, air goes in through that opening in the chest wall and leaks into the pleural space. And then when the contraction happens, that gas is trapped. So when the contraction happens and our chest wall muscles and our diaphragm are back at resting, and those lungs are being squeezed down in an effort to create positive pressure to force that gas out. Maybe some gets out, but not all of it gets out. And the lung size decreases, a lot like with our pericardial tamponade. The heart size decreases because of that pressure. The lung size is going to decrease because of this pneumothorax pressure. And then the next breath that the patient goes to take, more gas is sucked in through the chest, but the lungs never really get back to their actual size. Then they exhale and a little bit of gas goes out, but not all. And then the next time that they go to inhale, that lung inflates to even smaller, and wash, rinse, repeat until that lung actually will no longer expand at all, and none of that tissue is available for oxygenation. We'll start to see this now developing into that tension pneumo. This is the progression of the whole thing. And we'll start to see that pressure just continuing to build and continuing to build, and start to put some pressure on the heart and the mediastinum and on that inferior and superior vena cava, limiting that preload and making that obstructive shock happen right there in front of us. Our signs and symptoms of an open pneumo aren't really a whole bunch different than our signs and symptoms of a simple pneumo, other than the fact that there is an opening in the chest wall this time. We're going to have dyspnea. It's going to be referred to generally as a sudden sharp pain. Subcutaneous emphysema, if you guys ever get the ability to assess someone in any way, shape, or form that has this going on as a problem, it is cool and you should do it. This is gas bubbles that have actually now leaked into the subcutaneous tissue. And when you touch it or put your stethoscope over it and palpate it, it feels like popping bubble wrap inside your patient's skin. It's actually really kind of neat. We have decreased lung sounds still on the affected side. And this is going to produce those red bubbles on exhalation, our sucking chest wound. We're going to see that frothy, bubbly blood every time our patient exhales, because now there's air mixing with all that damaged tissue and the damaged blood vessels. Subcutaneous emphysema, yep. Feels like Rice Krispies or bubble wrap. It really is kind of neat. Can be seen anywhere from the neck all the way to the groin area, depending on the significance of the leak and just where those gas bubbles wound up. Here's another picture of our sucking chest wound. What do you guys think our treatment is?
Would you apply some pressure?
Fill the hole.
All right, I had a couple people there all at once. I heard, Sandy, I heard you first, so why don't you go for it?
I said, like, would you apply some type of pressure?
So first things first, yeah, you would. When you find that hole, you're going to take your gloved hand and put it over that hole, because we're trying to seal that leak. We don't want that gas being able to get into that hole anymore. So we take a gloved hand and put it over that tension pneumo. We're still going to concentrate on our airway, breathing, and circulation. Believe it or not, that gloved hand placed over that hole is actually a treatment for your patient's respiratory problem, a treatment for their subsequent breathing issues. It's not a permanent solution, because once you put your gloved hand over that hole, you're stuck there. But since respiratory is likely to be our problem, we are going to apply some high flow oxygen, 15 liters per minute by non-rebreather mask. We're still going to make sure we get those good lung sounds. And our definitive treatment, right here, we are going to apply an occlusive dressing. This is going to be one of those things that you're expected to know about when we get to the state exam. An occlusive dressing sealed on 3 sides. We're going to take this plastic dressing, put it over the hole in our patient's chest, and tape it on 3 sides. We only tape it on 3 sides because we want that pressure that has now built up inside of this patient to have somewhere to go. We want to occlude that hole with our occlusive dressing when they expand their chest wall and try and take a breath in. But when they contract their chest and go to get rid of all that bad air, we want that occlusive dressing to be able to let some of that pressure go so that lung can now inflate a little bit more. And then they take another breath and they oxygenate more blood. Plus, with our 15 liters per minute non-rebreather mask, this patient is getting better right before your eyes. You're treating your open pneumo. You're preventing it now from turning into a tension pneumo. You may actually see some of those signs and symptoms of shock get a little better. Always, when we're talking chest wounds and pneumo and tension pneumo and all that good stuff, always have an advanced level provider on their way to meet you. Never wait, but always have them on the way. Because when these things start to develop and we start to see some of the more negative signs and symptoms, we are in bad shape and your patient's in worse shape. So letting the hospital know what you're rolling with and trying as best to your ability to meet up with either your intercept or trying to make sure that you get them transported to the closest appropriate facility as soon as possible is going to be good medicine for this patient. Here's a picture of our occlusive dressing doing its thing. On the top, we have a patient who is inhaling. This dressing will actually suck right against that hole and form the seal that your hand was forming when you placed it over that hole. And then this is exhalation down here on the bottom. The built up pressure and the built up air when our patient exhales will escape through that open corner, and the occlusive dressing will be managing this injury. The amount of bleeding is generally not the huge concern with a sucking chest wound. There are not, unless we're talking inferior superior vena cava or aorta, we're not talking normally a wicked, very large, huge amount of hemorrhage. So we make our peace with making sure B stays intact, and a little bit of leaking from that hole isn't going to be our big issue. The fact that our patient has a collapsed lung and a developing tension pneumo is going to be the big issue. We generally make our own occlusive dressings, but there are some in the field that are available, just like your commercial tourniquets that we played with the other day. It's very simple to just take a piece of plastic that you have on the truck that will be sterile on the inside and place that and make our occlusive dressing. Or if we have these seals available to us in our gear bag, we use that. This is called an Asherman chest seal. That funny looking piece in the middle there is actually a valve. So instead of only being sealed on 3 sides, this would seal directly to the chest and cover that hole completely. And every single time that your patient exhaled, we would have gas escaping from that flutter valve in the middle of it. It's the exact same thing as what you would do with, your improvised occlusive dressing, but this is just something that works a little differently. We're going to monitor this patient's heart rate and rhythm very carefully, because we'll start to see some changes with our rate, rhythm, and quality of their heartbeat as a tension pneumothorax develops. So when you put your dressing on, just because this is supposed to allow air to escape, if you put the occlusive dressing on and your patient doesn't really begin to improve, they continue to get worse, it's pretty reasonable to say something's wrong, right? Not necessarily that you did anything wrong, because an occlusive dressing is the treatment for an open chest wound. But if your patient isn't improving the way that you expect them to, it's a pretty easy leap to make that something's not going well. If we're monitoring our heart rate, rhythm, and quality, of this patient, monitoring their mental status and monitoring their respiratory status, and we don't see those improvements, that's because our open pneumo is probably turning into a tension pneumo. One of the things you can do for that is actually break the seal on your occlusive dressing for a second when your patient is exhaling and see if more of that gas can get out, and then you put it back on before they inhale. It's called burping the dressing. You actually open it up when your patient exhales so that more gas can get out. And then before they inhale, you seal it again and see if that helps your patient get any better. We're going to maintain a patient airway. We're going to ventilate only if necessary because we don't want to force more gas into that pleural space and create the ugly stepsister here, monitor for tension pneumothorax. Tension pneumothorax will kill your patient for sure, without question. Tension pneumothorax is bad news. With a tension pneumo, we have air building in that pleural space and nowhere for it to go. We have collapse of the lung on the affected side, and we have a big buildup of pressure because there's nothing letting any of that pressure leak out. So every single breath just adds more pressure and adds more pressure and adds more pressure. We'll start to see some effects on the heart. We'll start to see some effects on the great vessels, so that jugular venous distension and our tracheal deviation way late in the game. We'll start to actually see some effects on the non-affected side now. So now, instead of just one lung being affected, we start to see all of these things beginning to shift and be pushed inside the chest and compressed against the other lung. And eventually we start to see the heart not being able to pump very well. And we'll start to see those cardiac changes we talked about, decrease in rate, rhythm, and quality. The heart might actually try to pump faster for a little while, but the quality and the strength of that pulse is going to diminish because that rapid heart rate for the short amount of time that it's going to be able to generate isn't going to have enough blood to pump out because of the obstructive nature of what's going on in that jugular vein distension, holding back blood from getting back to the heart. And we start to see now that obstructive shock, that typical thing that we look for when we want to talk obstructive shock. Signs and symptoms of my tension pneumo? Well, they're likely to be very anxious, very restless, and difficult to pin down. This is somebody who knows that they are in bad shape. We're going to have difficulty breathing, but it's going to be severe. This is a patient who is like gulping at the air, really having a difficult time, really can't catch their breath, can't breathe deeply enough. Instead of just having distant or quieter sounding breath sounds on the affected side, if you hear nothing on the affected side, you can really start to think tension pneumothorax, because this lung, this side of the patient's chest will be absolutely dead silent. And quiet chest is a deadly chest, period. Whether it's asthma, whether it's a pneumo, whether it's a tension pneumo, if it's quiet, your patient is in trouble. They're going to breathe very rapidly. They're going to have a rapid heart rate. But would you look at this? Their skin color, temperature, and condition is going to stink. How come? Why are they going to have crappy skin color, temperature, and condition?
Lousy perfusion.
Lousy perfusion. They are in shock and well on their way to decompensation. We'll see a lot of accessory muscle use because the body is now fighting the fight and calling in all its reserves and calling in all of its markers to try and get as much gas into it as it can with the amount of time it's got left to work. We start to see this jugular venous distension. Then we'll start to see narrowing pulse pressures. Now, yesterday when we talked head injury, we talked those widening pulse pressures with the Cushing's triad or Cushing's reflex. You know, you'll have a blood pressure of 240 over 70. And you have these great big differences between systole and diastole. And now with a tension pneumo, we see narrowing pulse pressures. So what's going on with the heart is, since it's being squeezed, systole and diastole are getting closer together. When we start to see those narrowing pulse pressures on our blood pressure, this patient's getting ready to code. We have, as much pressure now in the arteries and the veins equally, and the heart's gonna really begin to struggle when we start seeing these narrowing pulse pressures. This is the end cause. We're gonna get hypotensive to the point where altered mental status starts to show up, and maybe the patient goes unresponsive, or maybe you can't even hear a diastolic blood pressure anymore. You have just a really, really soft, really low systolic number. Put all these things together, and as you see them starting to pop off one by one, we absolutely do not need to wait until we get here, because look at all the things that would have happened first. Anxiety, restless, severe dyspnea, absent breath sounds, breathing fast, tachycardic, poor skin color, temperature, and condition. This is really just jumping up and waving its hands at us saying, hey, this patient's sick, especially if you can couple it with your mechanism and your patient's complaints. And really sort of, now you look at the whole picture and go, all right, well, I know when I'm seeing all of these things here on the left side, that eventually we wind up over here, and over there is really negative territory for my patient. So we get on about our business a whole lot quicker and make sure that we can do the things that we need to before we get to tracheal deviation. Super late in the game, if we see it at all. It's very, very uncommon. Best medicine is going to be airway, breathing, and circulation support, C-spine as indicated, high flow O2, including ventilation if need be. If your patient is beginning to fail, we ventilate. We're going to treat aggressively for our signs and symptoms of shock. We are going to request our ALS intercept as soon as we start looking at mechanism and we see the open chest and the marked severe respiratory distress. Don't wait for anything else. We're good here. This is important. This is something that is very likely to turn into a very negative outcome if we don't get on about the business of getting this patient to the closest appropriate facility with an ALS intercept en route. Always be on the lookout if you've applied an occlusive dressing for a tension pneumo beginning to form. Pay very close attention to your vital signs and your patient condition. The occlusive dressing should help your open pneumo patient begin to get better. If your open pneumo patient doesn't get better, or gets better for a time and then begins to deteriorate again, you're developing pressure inside that chest, and we need to go through the steps of burping that occlusive dressing. Not much has changed. Heart rate and rhythm, we want to stay very closely to our patient here and just constantly reassess mental status, airway, breathing, circulation, vital signs, treatments, mental status, airway, breathing, circulation, vital signs, treatments. Just stay right on top of all that stuff, because this can get out of hand fast. Make sure we maintain a patent airway. If your patient does go unresponsive, insert one of your airway adjuncts, OPA, NPA. It's your choice. Ventilate as necessary. If you have to ventilate this patient with a BVM, go ahead and do it. One thing that you can do that will be very, very beneficial to your patient and other providers is take note of any changes when you squeeze that BVM. Now, when you guys have been ventilating the mannequins, you pull the head back, you open the airway, you squeeze the BVM with a nice good seal, and the gas goes in pretty easy, right?
Yeah.
Pretty much.
Yep.
Yeah, it's not like you have to get, people together to squeeze that bag for you, and two people have to hold the EC clamp to get that good open airway and that good fit. That's called good compliance. When it is easy to ventilate your patient, it means the lung tissue is compliant and you're able to blow it open, and then it's able to relax and exhale all of that carbon dioxide. The worse a tension pneumothorax gets, the more difficult it will be to actually ventilate that patient, and that's called poor lung compliance. So if you get to a point where it feels like you're trying to, squeeze a breath from that BVM through the wall, your patient has developed some poor compliance because of all that pressure. We're going to skip through this because please don't put needles in people's chests until you become paramedics, okay? Here's a chest seal again. Holy smokes, we've been going for a while. Why don't we take a short break and we'll come back and finish this lecture off. I didn't realize I've been yapping at you guys for almost an hour and 20 minutes. So we'll take a break. When we come back, we'll finish the lecture, and then we'll get into some of the other things I have in store for us today.
Sorry, I was just running back getting a coffee. What'd you say?
I responded to your email. I just took care of that thing that you had asked me about.
Oh, okay, thank you so much.
Yep.
Hey,
All right.
Tommy, can you
Cool.
post your email in the chat? I was trying to email you, but it keeps bouncing back.
Yeah, hang on one second. I'll put it up there right now.
Thank you.
There it is, Malachi.
Thank you.
No problem. So here we go. We're going to get into hemothorax now. Hemothorax, when air fills that pleural space, we call it a pneumothorax. When blood fills up that pleural space, we call it a hemothorax. Generally speaking, this is going to be some form of lacerated blood vessel inside the thoracic cavity. So something inside the chest has ruptured and is now leaking blood into that into that pleural space. Blood is going to continue to pump in there, and it is going to continue to put pressure on the heart and the other vessels inside the chest cavity. Next, we have something just astonishing. Each lung can hold approximately 1.5 liters of blood. That is an awful lot. When you think of the fact we have 2 lungs and really only like 5 liters of blood, almost all of it could leak out as a hemothorax, and we would be in some pretty rough shape.
Tommy, I don't know if anybody else is having this issue, but I can hear you changing the slides, but nothing's changing on my screen.
Yeah,
Now it did.
I forgot to hit the play button. Mostly it was just fancy PowerPoint stuff sliding on. It was the same screen over and over again anyhow. So much like with our pneumothorax and the picture of air filling that space, now we have the exact same mechanism, only this time it is blood filling that space. And it fills up and fills up and fills up. And eventually we'll start putting pressure and squeezing on that heart. How does this happen and where does all that blood come from? Well, we have blood vessels and nerves running along the underside of each rib. We have blood vessels surrounding our alveoli and surrounding our bronchioles. There is a large blood supply inside of our thorax, and not even just in those big important structures that we think about right away, the aorta, the vena cava, the heart itself. We have just an obscene amount of vascular structure just in the lower portions of our airway alone. Then you start thinking, all right, now the tissues of the chest wall and the bony structures of the chest wall. And there is a pretty significant spot for leaks to begin to develop themselves. So we have hemorrhage. You guys tell me what some signs and symptoms of this might be.
Pale skin.
Pale skin, so yeah, so we have some poor skin color, temperature, and condition. I like it. What else?
Low blood pressure.
Okay, so blood pressure could start to fall because the patient's not filling the tank anymore. Keep going.
Becoming tachycardic.
So tachycardic because the heart's trying to work with what's left, so we're pumping that blood around even faster. What does this sound an awful lot like?
Cardiac arrest.
Cardiac arrest is coming, but what does it sound like this patient is going into?
Shock.
You got it. So we start to see some alteration in their mental status. That's going to be one of the things that I would look for right away if a patient has sustained an injury that I think is significant enough to send them into shock. I want to start with that mental status right away and see if I'm starting to pick up on anything. You know, does this whole thing smell funny to me? They're going to be breathing fast, trying to oxygenate as much of that blood that hasn't leaked into the pleural cavity as they can. We're going to see all of our signs and symptoms of shock. You know, altered mental status, pale, cool, clammy skin, tachycardia, tachypnea, some, you know, maintaining initially of their blood pressure, and then blood pressure will start to fall and the heart rate will go up even faster and the respiratory rate will go up even faster. Their mental status will continue to fall as they get worse. But we might have some frothy, bloody sputum. How come?
Might be bleeding into their lungs.
Yeah, air is mixing with that blood. We have blood free floating places where it shouldn't be. So if my patient coughs, I'm likely to see some blood tinge to whatever they cough up. We may have some diminished breath sounds on the affected side. This might even be one of those times where you can hear the blood kind of sloshing around, or you can hear some weird crackling because there is just a huge amount of fluid surrounding that lung, and it's all blood and it's all bad because it should be somewhere else. Tachycardia. Now this next one, I'm going to want somebody to explain it to me, because when we were looking at pneumothorax, tension pneumothorax, obstructive shock from cardiac tamponade, those kind of things, we had these great big engorged distended jugular veins. But if my patient has a hemothorax, I'm going to see flat neck veins. Somebody take a shot at it. Why do you think?
There's not enough blood pumping around to even inflate them.
Exactly. Our patient is profoundly hypovolemic probably at this point, and they don't have enough blood to maintain enough pressure to even engorge those jugular veins with an adequate amount of blood, let alone extra. So we'll see flattening of the neck veins with a patient who sustained a hemothorax. Now our treatments haven't changed a whole bunch, and they're still not going to change. We're going to monitor and maintain our ABCs. We're going to indicate and implement C-spine control as warranted. We're going to secure our airway and assist ventilations as needed. We're going to implement some general care for shock. What's my treatments for shock?
Keep them warm.
Keep them warm. Keep going.
Keep I don't know. I just want to. I guess I don't know. I lost my thought.
Okay, well, take a second and find it. What's my treatment for shock? You had to know I wasn't letting you go that easy.
Non-rebreather mask.
Okay, non-rebreather mask, 15 liters per minute, high flow O2. What's one more thing? We got 2 out of 3. Sandy, I want you to give me the third one. We have Non-aretha mask, high flow O2, 15 liters per minute. We have keep them warm. What's one more thing I can do for my shock patient?
Did we already say to assist with ventilation?
So as needed, we can assist with ventilation. Okay.
You already did the ABCs.
Yep.
Yeah, that's all I could think of, the ventilation.
What position am I going to transport my shock patient in?
Would you do the Fowler position with spine control?
No, a shock patient wants to be supine. We're going to lay them out flat. So lay them flat, oxygenate, and keep them warm.
I thought you would lay them up so that way they're not fighting against gravity to breathe.
So
And
that's
talked about in
our respiratory patients. Our respiratory patients, we're going to sit straight up. Our shock patients, since perfusion is the issue, I also don't want the blood vessels in the heart to try and have to fight against gravity to get blood back and get blood pumped out and those kinds of things.
Oh,
So we
okay.
want our shock patient to have a nice stable platform to try and pump around what blood is left in there. A patient with a hemothorax, we may want to transport in the left lateral position a little bit because the heart is sort of center left of the chest. We want that blood to be pulled away from the heart so the heart still has the ability to do its thing. If they're on a backboard, all we have to do is sort of wedge up the side of the backboard a little bit so that the heart will have room to do what the heart needs to do, which is pump oxygenated blood. But really, the end goal, rapid transport. For all of these, the end goal is rapid transport. These patients with a chest injury are ill. They have some pathologic things going on, and none of them are good. They are all negative, and we need to be on a move. We're going to contact ALS for these patients because we expect them to deteriorate rapidly. But this is definitely one of those situations where contacting ALS, yeah, sure, do it. But getting them to the hospital sooner rather than later is going to be our best medicine. A paramedic is not going to be able to fix a hemothorax. We don't carry blood. We don't carry fluids that will transport oxygen and pump up their volume. So really, what these patients need is a chest surgeon and some whole blood. And the only places we're going to find those are at the emergency room. So, yep, protocol probably dictates to us that we request a medic for this and get an ALS unit dispatched. But if that ALS unit is going to slow you down, you just wave as you drive right by them on our way to the emergency room. We're going to skip through all of this because all of this stuff is ALS level intervention. And we're going to move on to our flail segment. Here we have 2 or more ribs broken in 2 or more places. So the picture of this does a pretty decent job of, I think, showing you why this segment of chest wall would move independent of the rest of it. Because you can see that this little segment of rib here in the anterior portion of my patient's chest is freestanding. It is all by itself connected to nothing. And being in that fashion is going to cause my patient some difficulty in, first of all, even just wanting to breathe. And secondly, being able to do it any form or fashion of appropriately. So here we can see on X-ray, and I'll put yellow dots on where all these breaks are. So we have a rib fracture on the 3rd rib here. We have 2 rib fractures on the 4th ribs there. We have 2 rib fractures on the 5th rib here, and 2 rib fractures on the 6th rib there. So that's 1, 2, 3. So that's 1/3 of this patient's entire right side rib cage is now what we would call flail. This is going to move independently all by itself when my patient goes to expand and contract that chest wall and create all those pressure differences. And this is just gonna hurt like absolute all get out. And my patient will find them probably self-splinting, so they'll be holding it and guarding against you. They're gonna be breathing these tiny little like baby breaths, and they're really not gonna be moving enough gas to be of any assistance to themselves. Signs and symptoms of flail chest are, first of all, that visual that we will see, that paradoxical motion, but couple that with your patient's mechanism of injury and a complaint of shortness of breath. And then we see that paradoxical motion. Maybe we see some bruising or swelling when we IPA the chest during our breathing assessment. Maybe when we're palpating during our rapid trauma assessment, we'll hear that crepitus, those bone ends sort of grinding and mashing together. Flail chest is absolutely a true real for life emergency. And we have two treatments. First of all, ABCs, C-spine control as indicated, high flow O2, absolutely. We're going to monitor for any signs and symptoms of a pneumo or a tension pneumo beginning to develop, because there's sharp bone ends in there, and those sharp bone ends will eventually, sooner rather than later, probably start doing some damage to the lung tissue and letting gas leak into that chest wall cavity. And then we start having that pneumo developing, and that pneumo turning into tension pneumo, and that tension pneumo turning into obstructive shock, distended jugular veins, tracheal deviation, cardiac arrest. This is why I'm spending an extended period of time on this, because this is big business. This is absolutely things that will take your patient right out of the game, right in front of you. And they are things that we can fix, or at least have a pretty decent effect on.
Tommy.
Yo.
So, just as you're talking about flail chest, I just looked up more pictures because I don't know, I was having a hard time figuring out like what it looked like from your pictures. So, I see that like some, like when they break, they can break in two spots, obviously. So, like you said, and like they can detach completely. So, like, how do they? I mean, obviously the body must heal itself, but how does it come back and attach back to the, you know?
They'll get in there. An orthopedic or a thoracic surgeon will get in there with a screw gun and put everything back together.
Oh, okay, I was thinking, I didn't know if they did that or because you said like rib
And
breaks you can't really
probably take
fix.
some wiring and stuff to hold everything in place. It's a bad nasty. I mean,
Yeah.
it's not good. I'm going to show you guys a video that will probably make the picturing of this in your mind a whole lot easier. As long as, I think maybe it's on Tavuti. I'm going to look in there real quick, but if it's not, I'll find it again, because this guy has just a big honking flail segment in his chest, and you can see like exactly what it is that we're trying to put our finger on.
Okay. Thank you.
Yep. So here's our first line treatment. We're going to splint this with a bulky dressing. We take those trauma pads that we've talked about a couple of times, and we fold them up on themselves, and we take and we put those right over the flail segment. We hold that in place, and we will wrap around the patient's chest with some of the cravats we were using yesterday to make splints, and we're going to tie them rather tightly in place. This is another one of those don't expect a Christmas card type moments, because it already hurts and we're going to hurt it more. But what we're doing is actually now sort of what the orthopedic surgeon is going to do more permanently in just a little bit. We are now making that chest wall no longer move independently of itself. We have splinted that now, and every time our patient exhales, the splint is going to contract with it, and it's going to force that piece of flail segment into submission and make it exhale with the patient. And every time my patient's chest wall expands and my patient inhales, it's going to actually, the splint will pull that segment of flail chest out with it. And it will, in theory, increase our patient's ability to ventilate themselves a little bit better. We're going to contact ALS and transport as soon as to the hospital as soon as possible. Remember, 10 minutes with a significant trauma on scene is what we should be striving for, no more. Here is what the bulky dress splinting of a flail chest looks like. This is exactly why I told you that your patient's not going to want to be friends after this. Do you think this is like 100% successful?
No.
What do you mean by successful?
Do you think that the patient is, right after we do this, they're like, oh my God, I can breathe so much better now?
No.
No,
Not at all.
still gonna hurt. It was still a huge significant trauma, and there is still multiple broken ribs inside that chest. So our first line treatment is always going to be that bulky dressing. In your trauma scenario at the state exam, if your patient has a flail chest, treat it with a bulky dressing. But be prepared to assist with ventilations. Because if we assist our patient, this is someone conscious, alert, speaking to us, but their respiratory effort is so little and so small that they're hardly getting any chest wall movement because somebody just demolished their rib cage with a sledgehammer, that they're going to try not to breathe. And we will actually take over and breathe for them. And that really will start to splint this injury from the inside. Those positive pressure ventilations with the BVM is now making it so that my patient doesn't really have to do all that work, doesn't have to do all that expansion and contraction, because I'm doing it for them with the BVM. So as a provider, be prepared for that bulky dressing to not really have the effect that you're looking for. And if/when it doesn't, take over and ventilate your patient. You're going to, this is providing the best possible medicine for them. This is going to provide for them something that they're having a marked difficult doing for themselves. And you'd be amazed at how you can sort of turn this around a little bit. And you'll see your patient start to no longer be that pale, cool diaphoretic as long as there's no other significant injuries going on underneath. You'll start to actually see them pink up a little bit and regain their mental status and relax and actually just let you ventilate them. Because the brain goes, hey, this doesn't hurt anymore. And you're ventilating them and they just lay there and let you do it. It's the damnedest thing when somebody who's conscious is just sort of locked in with you and allowing you to ventilate them. Next, we're getting into cardiac tamponade. Pericardial tamponade is when blood leaks into that pericardium, the sac surrounding the heart. It's fibrous, it's tough, and it does not have any stretch. It does not expand. Every time the heart beats, the pericardium gets more blood in it. And sooner rather than later, that pericardium can actually become full and the heart will no longer be able to expand at all. When there's enough pressure and enough blood inside that pericardium that the heart can't relax anymore, what doesn't happen?
Doesn't beat anymore either.
Yeah, because it can't fill with blood. So there's going to be no more of this, right atria to the right ventricle to the lungs, lungs to the left atria to the left ventricle to the body, because the heart now has been compressed to such a point that it can't refill anymore. And the patient is no longer circulating any blood. As that pumping motion begins to fail, we start to see a marked decrease in our patient's blood pressure. The heart rate is going to go rocking out of control and try and increase as fast as it can to try and compensate. But what's it really doing at that point?
Not much.
Yeah, any of the blood that's in the heart, it's pumping it out faster, which means it's really filling that pericardium faster, which really means that the next thing that's going to happen is the patient's level of consciousness disappears completely, and the patient will go into cardiac arrest. You'll have no pulse, no breathing, no blood pressure, do not pass go, do not collect $200, and it is all the result of blood squeezing on that heart from the outside and not allowing it to refill. There's no real mechanical problem with the heart. There's no real electrical problem with the heart. The heart was minding its own business when it got squished to death from this blood inside the pericardium. Signs and symptoms of obstructive shock. Blood's being obstructed from returning to the heart. It can't refill. So we're going to have those distended neck veins. We'll have some increased heart rate, eventually getting real fast and then becoming zero shortly thereafter. We'll have some increased respiratory rate, eventually getting real fast and then becoming zero shortly thereafter. We're going to have poor skin color, temperature, and condition. We will have those narrowing pulse pressures. So systole and diastole, systolic and diastolic blood pressures getting very close together. Eventually they become even, and when they do, they are zero. Then we'll have hypotension. And the end result of all of this, not good. This is a patient who will go into cardiac arrest without some pretty significant intervention. Same. We're going to monitor and treat any problem with airway, breathing, or circulation. We are going to use C-spine immobilization as indicated. We are going to apply high flow O2 via non-rebreather mask. We will end up ventilating this patient. We will end up working a cardiac arrest if things don't break our way soon. We will treat signs and symptoms of shock as they arise. So the oxygenation, keeping them warm, laying them flat, rapid transport. With all of these same things, we're going to notify the hospital and get an ALS intercept if at all possible. This is the actual treatment of this, and I will go ahead and we'll walk through some of this. We'll see if I can't get a video of this happening as well. But pericardiocentesis is they take a gigantic needle and right next to the xiphoid process, they enter the chest cavity. They advance that needle at a 45-degree angle and are withdrawing on the plunger. They are actually going to put this needle into the pericardium and withdraw all of that blood. We're not going to do that, but I will show you a video of that because it's actually, again, I'm a nerd and I think it's cool, so you guys are going to have to watch it. Pericardial tamponade is a dire emergency. This patient will die, is going to die without rapid transport to the closest appropriate facility. Like, period, is going to die. They are on the clock for sure, and it is a very small, very short window to get this patient to the emergency room. Moving right along, we have traumatic aortic rupture. A traumatic aortic rupture is just what it sounds like. The heart is big and heavy and not really altogether that well anchored in the chest. It hangs off that aortic arch. This sort of, calling it a pendulum, is really pretty appropriate. So with rapid acceleration and deceleration, things like significant motor vehicle collisions, skiing injuries, the heart will actually get some swing to it and just completely shred the aorta and tear the heart right from the aorta. These are patients who will absolutely be in cardiac arrest before you even get there. Let's talk chances of survival here. Almost non-existent. Unless it is only a small tear in the aorta, which isn't very likely, the patient is not likely to survive. If the aorta is completely ruptured and the heart is completely torn away, the patient dies instantly, period, no questions asked. This is going to be worked like any other cardiac arrest. It is also a cardiac arrest that is likely to be an absolute bloody mess. This is not a patient whose prognosis is very good. But we will talk some signs and symptoms of traumatic aortic rupture. Now, somebody remember all the way back to our cardiovascular cardiology lecture. When we had an aortic aneurysm that ruptured, what was one of the hallmark signs I told you guys to be on the lookout for? It was a very specific kind of pain.
Tearing.
You got it. If your patient has a traumatic aortic rupture, but it's only a little one, they're likely to complain of the exact same kind of pain. They're going to have that burning, tearing sensation inside their chest. Feels like it goes straight through them and out their shoulder blades. It's the same mechanism. It's the same problem. The aorta has developed a leak. We're going to have a rapidly dropping blood pressure and a rapidly increasing pulse, but not for long. Because sooner rather than later, we wind up with a decreased or loss of pulse. We may see a significant decrease on the blood pressure and pulse on the left side compared to the right. And sooner rather than later, we wind up with rapid loss of consciousness up to and including cardiac arrest. I mean, that's where this is headed. Somebody stop me when they see something that is confusing. Are you guys sensing the pattern? We're going to maintain our ABCs. We're going to initiate high flow O2 up to and including a BVM. We're going to treat for shock. We're going to be ready to work a cardiac arrest. So if we have one of those sudden deceleration type injuries and we see a patient who doesn't really have a ton in the way of external injury, but their condition when you get there doesn't match what you're looking at for injury pattern, we start to think, all right, why do they have no blood pressure? Why are they significantly altered? Why is my blood pressure different significantly on the left arm versus the right? And we start to think, okay, well, I've kind of ruled out a whole bunch of other things. So I'm going to treat worst case scenario, and I'm going to think possible traumatic aortic rupture. It's not mine to diagnose anyway, so that really doesn't make a whole long ton of difference. But really, I'm going to treat those signs and symptoms of shock. I'm going to maintain airway breathing circulation at all costs, and we're going to boogie. It's time to go. We are going to rapid transport to the closest appropriate facility with an ALS unit en route. This is time to move. Traumatic asphyxia, sudden compression of the chest cavity. So something is squishing the chest cavity. Something is providing that external pressure from the outside, making the insides not work. We can have massive rupture of organs and blood vessels in the chest cavity. We may, when we talk signs and symptoms, some of them are really just terrible. Ultimately, if the patient isn't freed and their chest isn't freed from that compression and that constriction, the end result of all this is going to be death. Asphyxia means suffocation, so traumatic suffocation. Patient's going to have severe dyspnea, very, very distended neck veins. Why are their neck veins distended?
The blood can't
Because they're
return to
under
the heart.
so much
Yeah,
pressure.
you know, all of the great vessels and the mediastinum and the lungs and the ribs and the mechanics of breathing and the mechanics of everything important are being squashed. So that blood's not going anywhere. It's just going to continue to back up into the venous side, and it is not going to go anywhere besides into those neck veins and distend and bulge them out. Your patient, as they get a little sicker, is likely to have sort of bulging bloodshot eyes. You'll start to see like blood vessels looking like they are just exploded in their eyeballs. It's because they have, but the eyes will almost like bug right out of the head. They will be swollen in the tongue and very, very cyanotic. we will have reddish purple discoloration of the face. So the face and neck and chest are really likely to look almost like not human. We'll start to see some petechiae. Petechiae is like microhemorrhages, bursting blood vessels in the tissue. And until we get this patient out of the situation that they are in, the prognosis is not very good. Our treatment, ABCs with C-spine are as indicated. We're going to apply high flow O2. If the problem is that my patient cannot expand and contract their chest wall, that high flow O2 is going to be using a BVM. Now, if my patient's trapped under a boulder, I'm not likely to be able to get a whole bunch of ventilation into them. I'm probably going to have some pretty poor compliance with their lungs because their lungs are being crushed by a boulder. But that's what I have to work with. So I'm going to attempt to ventilate this patient anyway, even if they're still trapped and still pinned. And when they move, hopefully we have something to work with. We're going to treat for shock. We're going to keep them warm. When we get them unpinned, we are going to transport them supine and keep them warm. We're going to care for any other associated injuries. So this is one of those times where extrication and patient access could be a difficult thing, right? So it could take a little while to get this patient removed from whatever situation they are in. So we may take a few minutes to start splinting some broken bones and stuff on scene and working around trying to care for some of those secondary injuries on scene, because when this patient gets freed and when they get extricated from the confinement, they're going to be a handful management wise. So we need to be ready for some pretty significant patient deterioration. So caring for some of these secondary injuries while they're being extricated might be in our best interest, as long as it doesn't delay or get in the way of the patient extrication process. We're going to transport rapidly to the closest appropriate facility with an ALS intercept en route if at all possible. And then we just go on about our treatment and reassessment and all of that stuff in the ambulance on the way to that closest appropriate facility. And we are finally getting to the end here. We have a diaphragmatic rupture. The diaphragm develops a tear in it, and it allows the abdominal organs to actually enter the chest cavity. Now, that creates a multitude of issues. First of all, the diaphragm, responsible for us being able to get gas from the outside to the inside and used gas from the inside to the outside. So we're going to have a problem creating those pressure differences. And then ask yourself this question. Does it really seem like there's a lot of extra room inside that thoracic cavity for, feet upon feet upon feet of GI to wind up inside there, smushed against our lungs and our heart and the aorta and the vena cava? What do you think? Do you think there's a lot of extra room for all that additional stuff?
Not at all.
Yeah. So we will start to have some compression of the lung tissue. We'll start to have some changes in the seating of the heart and the ability of the heart to do its job to pump blood. And one of the big things that we may find when we do our assessment, I think is kind of cool, and we'll get there in a minute. Diaphragmatic rupture is more common on the left side. The liver is a very large organ, very thick and rugged. It helps protect that right side of the diaphragm. So we will see this more often left versus right. But let's call it what it is. It is associated with multiple injury patterns. It is not very likely that a patient's single complaint or single finding is going to be a diaphragmatic rupture. This is, probably multi-system, probably very, very sick. And we can see a picture of it right here. If you look on this x-ray, we have on our patient's right side, this is the chest cavity. That right there is the diaphragm on our patient's right. There's our lung, there's our right side pleural space. And over here, we have our left lung taking up very, very little space. And right here, we have the stomach inside of the thoracic cavity. So that is a time where one of our intriguing assessment findings may happen. First of all, this is pretty straightforward. We're going to have some abdominal pain, upper quadrant abdominal pain. We'll have shortness of air, so a patient who just feels like they can't get enough breath. They feel like they can't breathe well enough. We'll have decreased breath sounds on the side that this rupture has occurred. And last but not least, we will be listening for lung sounds and actually hear bowel sounds inside of our chest cavity. So when we're listening, we get good breath sounds at the apices. Maybe we get breath sounds in the mid lobes. And then when we take our stethoscope and put it mid-axillary and we're expecting to hear breath sounds, we will hear actually rumble guts. And we will be able to hear bowel sounds where we should be hearing lung sounds. I'm not a smart man, but I know that's not a good thing. Our treatments, here we go again. ABCs with C-spine control as indicated. High flow O2, including up to BVM and ventilating this patient with rescue breaths, 1 breath every 5 or 6 seconds. We're going to treat our associated injuries. Our associated injuries could be just about anything because the diaphragm is pretty well housed and protected. So expect a lot of injuries, some pretty widespread, pretty diffuse injuries. Like I said, it's not going to be a common thing that the patient's diaphragm just decides, well, we were involved in a small trauma, gonna rupture today. Rapid transport, care for shock, and contact the hospital. Rendezvous with ALS as available. So we talked impalements off and on a little bit, and when we were doing that soft tissue injury, and this is sort of what I was explaining to you guys about how to build a bit of a foundation for this impaled object to not be moving all around. They just started stacking up blankets and stacking things on top of each other to protect this knife from being jiggled around. The more that knife has the ability to move, the more damage it is going to do to any of the underlying structures. We are going to do our best to actually seal around where that knife penetrates the chest. We want them to hold their breath as we're placing the plastic material. So your ambulances actually are equipped with a roll of like Reynolds wrap. And this would be one of the good times to use it. We're going to go ahead and take that and wrap and seal around where that knife is meeting the chest in an effort to stop that pneumothorax and tension pneumothorax from developing. And we have made it to the end of that lecture. So now let's toss on a couple of videos here. Here it is. So here is our video of a patient with a flail chest. look what's going on right here. You see that bulging? That's our flail segment. That's where we're going to put our bandaging material. That's where we're going to do our splinting and tie that to my patient's chest in an effort to get these things moving in unison again. Now let's find. So here's a sucking chest wound with a seal on it. So we have an occlusive dressing in place here.
Haven't tried yet.
And you can see that that plastic is actually sucked into the hole to keep that occluded. No, we're not watching how to do needle decompression. And I'm just looking for one more to show you what it looks like before the dressing actually goes on. I believe these two are the ones.
Do you have an air leak now?
Can you guys hear that?
Do you have an air leak now? Just double checking.
You hear that gurgling sound. You can actually see the lung tissue. Here's another one. You can see the bubbles every time the patient exhales. Pretty gnarly, right? Is anybody still out there?
Yes.
Absolutely.
Okay. So you guys saw all that, right?
Yep.
Crazy. And we can fix that. Occlusive dressing, we're off on our merry way for our sucking chest wound. We see that paradoxical motion. We see that flail segment. Once again, off about our business as soon as we put that bulky dressing in place to now splint that from the outside. And if/when that decides that it's no longer adequate, we are going to now ventilate the patient with a BVM to splint from the inside and hopefully turn this day around for that person.